Hello. In this session, I'd like to discuss with you the mechanism of action of antidepressant medications. Before we begin, I'd like to reiterate that this video does not substitute common resources like UpToDate or your textbook of psychopharmacology. Much of this content is derived from Stephen Stahl's book, Stahl's Essential Psychopharmacology, from the work of Daniel Carlett, and the book Biological Psychiatry by Jock Panksepp. Antidepressants and SSRIs in particular are a common group of medications that are prescribed. In the United States alone, it is estimated that prescriptions occur about 6 per second, 24/7 around the year. I'd like to first begin by talking about the monoamine hypothesis. This hypothesis was developed about 50 years ago after a number of researchers performed the tryptophan depletion challenge, with tryptophan being a precursor for serotonin. And these researchers found out that a dietary restriction of tryptophan resulted in an acute decrease in brain serotonin and following depression within the subject. This proposed a biological and/or a neuroanatomical basis of depression as a deficiency in control of adrenergic and/or serotonergic systems. And somehow, if we were able to target these hormonal deficiencies or neuronal lesions, we would be able to restore normal functioning in a depressed patient. Now, the hormones that are crucial in the monoamine hypothesis include serotonin, norepinephrine. These two hormones are central, and in some cases, although the data for this is weak, dopamine. I'll put a star here as this is an exception. Now, let's discuss what happens at the neuronal level. Now, here is a neuron, and for the sake of clarity, we'll label certain regions. So this space is the somatodendritic region. This space is the synaptic cleft. Over here we have the this is the post-synaptic membrane, and likewise this is the presynaptic membrane. I'm going to label that. The yellow dot in itself is 5-HT, or serotonin. This is the 5-HT1A autoreceptor. Over here we have the 5-HT1A receptor, and this, or these, is the SERT proteins, or the serotonin reuptake proteins. Now, what happens is that the 5-HT1A autoreceptor is inhibitory, which means that when the 5-HT comes and attaches to the 5-HT1A autoreceptor, it would reduce the firing of this neuron, which would downstream minimize or reduce the ejection or production of serotonin in the synaptic cleft. With the introduction of an SSRI, the selective serotonin reuptake inhibitors, which would bind over here. Let's say this is the SSRI, and over here they essentially block the reuptake protein, causing an increase in the level of 5-HT in the somatodendritic region, with also some increase in the synaptic cleft region. Now I want you to hold this thought in mind, that blocking the SERT protein by the SSRI would lead to an increase in serotonin in the somatodendritic region, and also somewhat of an increased serotonin in the synaptic cleft. Now, Stephen Stalls, in his book, mentions that depression or depressive states are because, or in depressive states, there is a pathological upregulation of postsynaptic neurotransmitter receptors. And by this, we mean an increased number of 5-HT1A receptors. In this case, we have 1, 2, 3, 4 receptors over here. Now, with the introduction of the SSRI blocking the SERT proteins, the levels of 5-HT or serotonin increase. That has been depicted in our figure 2. And if you want to compare, we can see there is more serotonin over here in the somatodendritic region. And what this inadvertently does is it downregulates the 5-HT1A autoreceptors. As you can see, we had 1, 2, and 3 receptors here, and after serotonin was increased, we just have 1 receptor here. What this leads to is an increase in serotonergic transmission. Which downstream causes more release of serotonin. And keep in mind that during this time, these SERT proteins are blocked by the SSRIs. Now, this increase in serotonin eventually, over a period of 2 weeks, cause downregulation of the 5-HT1A receptors. So over here we had, in the first diagram, we had 4, and in this we just have 2 receptors, and of course these numberings are just for the sake of understanding. And remember, we started off over here that depression is a pathological upregulation of postsynaptic neurotransmitter receptors. With the increase in serotonin, there is downregulation of these postsynaptic receptors. And once this balance is achieved, once there is increase in serotonin and decrease in the receptor density at the postsynaptic membrane, this is said to have beneficial effects on depression. Now, another thing that needs to be discussed over here is that when there is this increase in serotonin in the synaptic cleft, the process of downregulation of the 5-HT1A receptors takes about 2 weeks. And these 2 weeks are said to be the time over which adaptive changes occur in these receptors, which translates clinically to the time to response that we see with SSRIs. And this is true generally for both SSRIs, SNRIs, and other antidepressants. And at the end, I would just like to reiterate 2 points, that there is, number 1, a desensitization or downregulation of the 5-HT1A autoreceptor in the somatodendritic region, which is over here. Number 2, this increases serotonergic transmission, causing an increase in release of serotonin, which over a period of 2 weeks, and again this is the time in which we observe clinical response, over a period of 2 weeks there is downregulation of the postsynaptic 5-HT1A receptors. Also, when there is downregulation of the postsynaptic 5-HT1A receptors, that is said to be the time when patients usually develop tolerance to side effects like nausea, vomiting, dizziness, or abdominal symptoms. And to compare and contrast, I'm just going to zoom out a little bit. If you like this video, please do click like and subscribe, and do comment in